All right, let's get started. Good evening, everyone. Welcome to the FPMRS Fellows webinar series. This is a joint effort between AUGS, SUFU, and SGS, and we are grateful for their support of this endeavor. I'm Jocelyn Fitzgerald, the third-year fellow at Georgetown MedStar, and I will be moderating today's webinar. Today's webinar is Intraoperative Care and Management of Lower Urinary Tract Injuries, presented by Dr. Elizabeth Mueller. Our panelists today include Dr. Leslie Rickey from Yale and Dr. Maggie Mueller from Northwestern. The webinar will feature a presentation for 30 to 40 minutes, at which time we will present some clinical cases for discussion between panelists. We will open the webinar to questions from the audience for the remaining time. In case anybody is here for the first time, I'd like to briefly review some housekeeping items. This webinar is being recorded and live streamed. All participants will be on mute, but please use the Q&A feature of the Zoom webinar to ask any of the speakers questions. We will try to address as many as we can within the hour. Please use the chat feature if you have any tech issues. AUGS staff will be monitoring the chat and can assist you. At the end of the webinar, you will be prompted to complete a brief survey and provide feedback about our session. I also wanted to let everybody know that our next webinar is scheduled for Friday, May 8th at 10:30 a.m. Eastern Standard Time, and it is on urinary tract infections by Dr. Kio Nahira with panelists Dr. Jen Anger and Dr. Lenore Ackerman. Please visit the AUGS website to sign up. And now it'll be time for our expert presentation on intraoperative care and management of lower urinary tract injuries. Dr. Elizabeth Mueller is a professor of female pelvic medicine and reconstructive surgery and urology at Loyola University, where she is also the division director of FPMRS, as well as the fellowship program director. So I'll hand it over to you, Dr. Mueller. Thank you for being here.
Thank you. Okay, Jocelyn, are you seeing my screen?
I see your screen.
Okay, well, we're good to start then. Well, I'm thrilled to be here. First off, I'm really grateful that I have my great colleagues, Maggie Mueller, Leslie Rickey, who are going to join me and pose some questions. And man, am I expecting questions from you guys too. And you see my disclosures? Now, really, what I wanted to do, and when I thought about this, I wanted to treat this as if we were in the OR together. I'm a talker during the OR. I know Leslie is. I'm pretty sure Maggie is. And these are the exact things that I'm saying to my fellows during an operative case, especially if we've had a complication. We're going to talk a little bit about bladder injury and ureteral injuries. And we're going to save the urethral injury for a case discussion that we have towards the end. So I really want to get to those. So let's start. Well, here's a bladder injury. That's a sobering, isn't it? We've all seen stuff like this. But let's talk a little bit about what is one of the most important principles when we think about bladders. It's the location of the injury. Now, very few people really think through all this stuff. If you are looking inside the bladder during a cystoscopy, let me tell you something. The anterior wall doesn't look any damn different from the posterior wall or any part of the bladder. And yet, how is it that if we perforate with a TVT, we treat things very differently than if we perforate during a hysterectomy, the bladder? And it's based on the location. The treatment for bladder cystotomies is based on location because fluid flows, and that results in the cystotomy not closing, when there's a pressure gradient driving fluid across the cystotomy. And then when it comes to thinking about a cystotomy, make sure you understand the pressure gradient. So here we are, I've got the classic Netter's picture, and I've got the woman placed just like we would during a TVT, right? Her legs are up, we're gonna pass behind the pubic bone, and what you see is the air bubble is not at the dome, for God's sake. It's up at the anterior bladder wall. The highest part of the bladder is the anterior bladder wall. If you perforate here, you are perforating into the spacer retius. And guess what? That is finite. So during that case, you have a cystotomy. We reposition the TVT. We then go ahead and check again. Things are good. We see the hole. We don't worry about it. We send women home now without even a catheter. Now, fluid is coming across that cystotomy, but it's equilibrating, meaning the pressure inside the space rettius balances itself out with the pressure that's residual inside the bladder, and that lack of fluid movement allows that to close. Very different than where we're looking here at the posterior wall or the dome sometimes of the bladder. There, the fluid, the pressure gradient is from the bladder to the peritoneum. And that space is finite. It goes, or infinite. It goes on forever. So fluid will continue to flow. We cannot reach equilibrium, especially with peritoneal circulation and reabsorption. We all know that happens. If you're in spills in the bladder, we know that we'll see rises of creatinine serum. So we know that there's a circulation. So that's what makes those two different. A perforation in a bladder is different based on its location. And I hope that makes sense. Now, when you're doing a case, and we all know this intuitively, what are the signs of an intraoperative cystotomy? Well, first, blood in the catheter, and that may not be something you notice right away. Blood would be, if the person's in Trendelenburg, then most of that urine and blood are coming into the surgical field. If you're doing a laparoscopic case, that may be sliding down and it's filling up down by the liver and you're not noticing it. Certainly difficulty visualizing during a cystoscopy. Remember that red cells are spherical. They're actually, a concave disc, biconcave disc, and they refract light, and that's why it looks so cloudy and difficult to see. So the first time you're looking in the bladder, even if you're not seeing blood, but you're having difficulty focusing, start thinking about an injury. And then lastly, of course, during laparoscopic cases where intra-abdominal pressures are high, you're going to see the Foley bag fill up with air, and we have all seen that in cases. So those are some good signs. Now, how do you close an intraoperative cystotomy? Well, the trick really is like grows to like. So you need two tissues that are similar without getting a different kind of tissue involved. So I always make a point of closing that mucosal layer first, and I make sure to get a big bite of mucosa. And we're going to talk a little bit about the corner in a minute because I think that's critical. Then I close the second layer. I test the closure with fluid, and I don't test the closure until I've got two layers in, because if you truly got that mucosal layer in, it's going to tear if you fill with fluid, and we don't need any of that. So I wait till I close the second layer. I make sure that second layer is imbricated. I go past that suture line, especially on the corners, which I'm going to talk about. And then often I'll bring in an omental or peritoneal flap as needed. I've brought in sigmoid, anything that's between the bladder, and especially since I'm often doing this with sacrocolpopexy, between the bladder and the mesh. If I can't find anything, I don't find peritoneal flaps to be as easy as everyone says. Sometimes what I'll just do is do a third layer on the bladder. The bladder's got plenty of room and it will remodel. And then I keep the Foley in place for 2 weeks. One thing that I think is critical, we all know the idea that suture lines should not be under tension. But we all have a panic when we see a cystotomy, and we'll often close it before we place the mesh or tension the mesh. And I'd like to remind people that, hey, that's okay. But after you've tensioned the mesh, believe me, you've changed the tension on that suture line. Go back and maybe take down your bladder flap a little bit more. Or before you close the bladder, close the cystotomy, take down the bladder flap farther than you normally would, and that will give you some extra space so that you don't have tension. And I know this from firsthand experience because I had someone referred to me who developed a fistula following a sacrocolpopexy, and I believe that was one of the issues why. So here I want to make a real classic point. If you do vascular surgery, and certainly in the urinary tract urologist, many of us like Leslie, we both learned how to do kidney transplants, so we learned vascular surgery. They make a very clear point that sutures don't start straight. You really have to get to the corner and go into that corner at a 45 degree, grab that mucosa, come out at an angle and grab that mucosa, and then start running your sutures. And I had a publication where they made a picture, and you can see exactly what I'm talking about. Look at that corner. See how that little hole is there, that little divot? You want to make sure that that corner is tucked in. especially on the second layer. I make a big point of coming past my original suture line, putting in a 45-degree imbricating stitch on both sides, and then before I tension that, I pop that in so that mucosal edge is inside the bladder. The majority of times when I've seen fistulas, I've seen them on the end of the original cystotomy closure. So I think that's a good point to make. Now, principle number 2, the things I want to talk about here are when there's an unrecognized cystotomy, the urine always finds its way out through the lowest gravitational incision. And we don't have time today for me to describe some cases that were really bizarre, where there was not a vaginal incision. Instead, there was an incision, colectomy, and the person presented with diarrhea. So I've really learned this over time. The fluid tries to find its way out. It usually finds its way out through an incision line. If that's on the abdomen, if that's in the vagina, that's where you'll see it first. So vaginal leakage of urine in the early post-op period, the first couple days, maybe even a week, it's not a fistula, it's a miscystotomy. And with that thinking, it might prompt you to not wait 6 weeks to go fix it. So I really want that thought to be clear. A miscystotomy, something that you see in the early postoperative period, should be treated. In gynecological cases, this usually means that a miscystotomy will result in urine finding its way out through the vaginal cuff. But if you're a colorectal surgeon who has an injury to the bladder, you're going to see it as diarrhea. When chronic, this becomes a vesicovaginal fistula, which is beyond the scope of what we're going to talk about today. Now let's just shift gears and talk a little bit about ureteral injuries. Now, Leslie and I can tell you, as urologists, we are the experts at ureteral injuries. Urologists cause more injury to the ureter, and there are cases where we absolutely will go in, fracture the ureter. So when we do something called a urethral dilation, we go in with a balloon, we blow it up under pressure, we essentially crack the ureter, and we don't even consider it a success unless on a retrograde we see massive extravasation. And how do we treat it? Well, we don't go in and close it. What we do is put a stent across and a Foley catheter in place. And we're going to drive that home later in a discussion. That when that urine comes down the Foley, comes down the stent, the cohesive properties of water with the hydrophilic nature of the stent will drive that water into the bladder. You've got to have a Foley in place so that that urine goes out of the body and doesn't reflux up on the other side. A very classic case that I think should make you really understand the healing properties of the ureter is that in the old days, in lithotripsy, before we had endoscopic procedures, we would do stone, crack it up. It would be in small pieces. It would totally fill the ureter, and it was called Steinstrasse, street of stone in German. And the treatment for it was to go in, make an abdominal incision, and incise the ureter all the way from the renal pelvis down to the bladder, put your finger in with a Raytech and slide the stones out to the bladder and just lay a stent down. We never closed it. So I'm trying to show you in that extreme example how the ureter with a stent in place and a Foley catheter can divert urine sufficiently and the ureter will heal. So our stents and retrogrades and understanding ureteral injuries really is within the armamentarium of today's current urogynecologist. Now, one thing is I evaluate the ureter wisely as a principle for me. So if the only injury you can have is an obstruction, like colpoclysis or uterosacral ligament suspension, it'd be far-fetched to believe that during a colpoclysis you're going to cut the ureter. It's far-fetched for me to believe that. Or uterosacral ligament suspension, just without a hysterectomy. Then passing a double open-ended catheter blindly should detect obstruction, but it's not adequate for a hysterectomy because in that case we could have cut the ureter in half, and you're passing a stent up through a transected ureter. Your question is not just obstruction. Your question is the ureter have integrity? Is it patent? Do I have both ends? And so you have to learn to develop skills of performing and interpreting retrograde ureterograms and nephrograms. And we're going to talk about that. Ureteral catheters that are good for retrograde imaging are the cone tip catheter or the whistle tip. Ureteral catheters that are used over wires are called open-ended. There's some special open-ended catheters. Ureteral catheters that are used over wires for difficult situations. Very few of you will use these, but we use them for stones. I use them for when there's a gap between the two ends of the ureter that's 2 centimeters. Sometimes that can take me an hour to get a stent across, and if I'm successful, that woman can actually kind of regrow that ureter if the ureteral plate is left in place. Wires, they're used to pass double open catheters or stents into the renal pelvis. They have a hydrophilic coating. There's angle, there's straight tips. There's ones that are flimsy. You don't want to use those. A Benson guide wire is very good. It's a regular guide wire, and those are the ones that you're probably used to. And then there's super stiff wires for unique situations. Renographin, we know, is an important part. Radiopeg contrast has small amounts of iodine, and certainly it can be used in patients with iodine allergies because it doesn't go into the bloodstream. We like to dilute it with 50% saline on the table, and that is because it allows us then, it allows it to not be so opaque that we won't miss a stone or some other abnormality. And of course, we all know about fluoroscopy. Takes continuous images. The images are reviewed. You really are viewed on a monitor, and then you want to select the images that are saved. You want to pick the ones that meant the most to you and told the story. And of course, with fluoroscopy, just like any procedure, just like urodynamics, I would say, I think that's the closest to it. You want to come in with a question, and you want to then make sure your question's answered, and then save the images that show the answer to that question. So retrograde nephrograms, again, I talked about using a cone tip, whistle tip, or olive. You inject 5 to 10 mils of 50% dilute contrast. The normal renal pelvis and ureter hold about 4 to 6 cc's. And if you put too much in, that pressure is going to go back through pilovenous backflow, can make someone very sick. And you want to know what the question is. Now, in intraoperative retrograde, you just inject the renographin. I'm usually looking for patency. Does the contrast get to the renal pelvis? If it's patent, then I'm looking for constriction. Is it deviated medially but not obstructed? If it is obstructed, I'm asking questions like, is the suture permanent or absorbable? If it's an absorbable suture, many times I'll just place a stent and leave it in place for 8 to 12 weeks while that suture dissolves. Sometimes you can place some reverse Trendelenburg to promote excretion if you're looking to see if the ureter is if the jets are gonna shoot. And then you have to decide, are you gonna do a stent placement if there's a obstruction versus urethrolysis versus suture removal. And we'll talk a little bit about that more later. And of course, if it's not patent, you wanna know if it's blind-ended or transected. Now, in order for me to kind of tell you about what to look for in a retrograde, I am going to have to explain to you some kidney relationships. So let's take a look at this image on the left. We're looking at a CT scan, just like a CT scan kind of image. It's cut at the level of where the kidneys are. We can see the 2 kidneys, they're very obvious, and look what they're lying on. They're lying on the psoas muscle. Now let's go over to the right side, the cadaver dissection. Look how the psoas angles out. We're going to use that to help us understand if we're seeing a single kidney, a normally shaped embryologic kidney on each side. So just remember that. That's the normal lie of the kidney is on that psoas, and with the top parts of the kidney kind of angled in and the bottom parts of the kidney flared out just like the psoas muscle is. So when we're shooting a retrograde, we want to look for locations, the location of the kidney, that's important. You'll especially use this later when you're trying, after you place a stent, you want to know, is the stent in the right place? Did it fall down? You're going to have to be able to read an image. So that's what this is for. So I start up, the last rib coming off is the level of T12. That's very obvious, and you get that, you get the fluoroscope up there, the fluoroscopy image, so you can see that bottom rib, you know that's T12. You count down, there's L1, L2, L3, and the left renal pelvis is classically across from L2, and the right renal pelvis is classically across from L3. Many times when you're placing a stent, you're driving the wire all the way up to the top of the calyx, and that's where the stent is going to curl. Don't ever be surprised if on the left side you're higher than L2. You can't place it too high. You're not going to drive a stent through the renal parenchyma. But where we worry is if it's too low. So remember, L2 are higher on the left side, L3 are higher on the right side, then you know you got that stent in the right place. What happens later? Oh, that woman stands, that stent plops down into the renal pelvis, and because of its curl, it doesn't move. Now, the location of the kidneys. We talked about the location, the size of the kidneys. Typically, the size of the kidneys is 2 to 3 vertebral bodies. Very often, you can't see the nephrogram like we're seeing now. We're seeing a nephrotome. We can see the outline of the kidney. That's a delayed CT contrast image. But if you do, it should be about 3 to 4 of vertebral bodies in length. Now let's talk about, is it oriented correctly? And this is important to understand if you have a ureteral duplication and you're just seeing one of the ureters. So first you outline, you put a dot on where the upper pole is. Now you put a dot on where the lower pole is. You draw a line between the two, and look, it's following exactly that lie of the psoas muscle that I showed you in that previous cadaver dissection. And then, of course, we want to look at the configuration. There should be 3 to 5 major calyces visible. Now, some of those are coming right at you, are coming right away from you. And because of the contrast being so opaque, we can't see it. But each of these kidneys has a normal configuration. Now, let's look at this, this image. So we have a kidney where we're looking at the 2 poles of a duplicated ureter. And I want you to take a look. Now let's say that one of those ureters was sitting in the bladder and the other one was at the bladder neck and you couldn't see it. You shoot your retrograde. There you go. You draw a line through the top pole of this lower renal unit. You draw a line through the lower pole. This is on the left side. Do you see how it's not lying like it would with the psoas? And neither is the one above it. That's a sign right there that you have a duplicated system and you're only seeing one of the renal units. And if you can imagine, look at that now, that image without the upper one. We call that the drooping lily, the way that it just hangs and makes that angle. Classic sign that you have the lower pole unit of a duplicated system. Now, when I ask a question, why is a transplanted kidney placed in the pelvis? Well, I can tell you why, because when someone donates their kidney to you, they don't give you the whole aorta. And we know that the kidney to be viable, they give you the renal artery, you get the renal artery, you get the kidney, and guess what? It's only the upper part of the ureter that has its blood supply from the renal artery. And so your transplanted kidney is always planted in the renal pelvis due to the viable ureteral length. In fact, when we're doing a transplant, many times after they've transplanted the kidney, they'll look at the ureter to see how much of it is viable and then cut and place into the bladder. Now, this is important for when we're thinking about ureteral blood supply. I'm hoping that just that memory will solve that question for you on the test, that you'll remember the upper part of the kidney comes from the renal artery, the middle comes from the gonadals, are off the aorta, and the lower comes from the iliacs. External iliacs. So if we we have the blood supply here, and it's the blood supply that really helps us understand whether or not a ureteral injury is going to be viable. Do we have to reimplant it, or can we go ahead and try to do an end-to-end reanastomosis? So we have a case, a 61-year-old patient's undergoing a laparoscopic hysterectomy and BSO for uterine fibroids that were symptomatic. At the end of the case, the cystoscopy reveals the ureter is not effluxing urine. Inspection reveals the left ureter is dilated and incorporated into the pedicle that contains the ovarian artery. So you identify the pedicle, you take down the pedicle, you can see both ends now of the ureter, which look okay, it's transected. What are your options and what are your concerns? Well, your options really are ureteral, ureterostomy, putting the 2 ends together. That's one of my favorite options if I'm doing a laparoscopic case. When I'm doing it laparoscopically, I'm willing to take a risk, especially if this was not just a cautery injury. If it was a cautery injury, if it's in a pedicle, that's different than a cautery injury. A cautery injury, I would go back a good centimeter on each side and then spatulate it, put it together. But if it's just wrapped in a pedicle and has been cut, then probably I would do, if it was laparoscopic, I would do a ureteral, put a stent in place, leave a Foley in for about a week, and then let that heal. Why would I, if it was an open case though, I would always reimplant. The success rates for implants are just really phenomenal. They can be in the high 90s. And as a result of that, I think most people, if it was open already, would go ahead and reimplant. But if you're laparoscopic, you're not going to convert to open. I think it's worth it to give it a try. Over the last few years, I've probably done 5 or 6 of these, and one of them had to go on to have a ureteral reimplant robotically. The rest of them did well. Although you hear everyone talk about a transureteral ureterostomy, very few urologists will actually perform them. Come on, you're putting both kidneys at risk with a single ureter, and so very few of us do it. And then there's, of course, the ureteral reimplant. So I kind of talked about these already. If the clamp or ligature is discovered on a ureter, then remove and inspect. If there's suspicion of ischemia, then ureteral stent 4 to 5 weeks and shoot a retrograde with stent removal. If it's a cautery injury, remove part of that ureter. If it's transected distal to the brim, then assess the blood supply. You can do a ureterostomy or ureteral reimplant. And then if it's transected proximal to the pelvic brim, either end to end, then typically I'll do a ureteral anastomosis. And again, the transureteral is safe for distal and rarely done. So, oh good, I've left some time, which I'm really pleased about. I might have gone a little fast so that we could talk through some of these cases. So Leslie, Rickey, and I trained together at Loyola. I'm happy to say that. We worked together for at least 8 or 9 years. So she's now at Yale, and I asked her to join us. And Maggie Mueller did a fellowship for a year at Loyola. She has a great interest in ureteral injuries. We're always talking on the phone. And so I'm excited to have them both here to kind of talk about lower urinary tract injuries. And so I'm going to stop my share now. I think that's the gist, right? And we're going to do the videos. Okay? So how are you guys?
Hi, great talk, Beth.
Okay.
Yeah, that was awesome.
I kind of talked fast. I was a little nervous. I couldn't tell how much time I had left. So let's start with the cases. I've got the cases here on my screen. We've kind of talked about them. I'm going to start with you, Leslie, and ask you, so you have a colleague who consults you the day after they first off, let me ask, was there anything you would have added to what I said? Is there or a point you want to reiterate that maybe I meant to say it, but I didn't? You guys both hear me talk about this pretty much. Do you want to add anything?
No, I thought the anatomy review was great about how to interpret a retrograde. I think that's very valuable. The one thing I wanted to point out to the trainees is they might say, well, why wouldn't you always do a ureterostomy? And I think in our training, the thought is that that suture line can create a stricture or a narrowing. And so traditionally, sort of the gold standard would be to reimplant if you can, because the ureter is so thin, you could create a stricture there. However, like Dr. Mueller was saying, if you're laparoscopic, if your choice is to go open or try it, and she's had good success with that, and I don't know that we have a ton of prospective data. So that's just the rationale behind why not always just do a ureterostomy.
Yeah, I mean, for sure. I think certainly I would have to tell you that I would personally believe it's risky to do it if it's already an open case. You might as well just do the ureteral reimplant, because you haven't saved that woman anything. But if you do it laparoscopically, then you've saved that woman an open procedure. Mm-hmm. And you can go back and still do the ureteral reimplant robotically. Right. So I think that that's a good call. One thing that point you made though is beautiful, which is, it's those radical hysterectomies that are, I think, the most disastrous when it comes to the ureteral blood supply. It has absolutely been obliterated. The ureteral blood supply, they've taken off everything on the lateral wall. They've taken down, they've really skived, they've really
skeletonized
the ureter. I mean, my God, I've gone into cases where the ureter looks like it's on the other side practically. It's lost all of its form. That ureter doesn't have much blood supply. That is a lousy ureteral anastomosis, I have to tell you. That's the one that I would reimplant. That's because even though that ureter doesn't have a good blood supply, guess who does? The bladder. The bladder's got a great blood supply, and that's why we see those success rates so high. So again, I think it's thinking through, we need the tissue to heal. Ureters that don't have good blood supply just don't fall off. What they do is they develop a stricture, like Leslie was saying. They're always ischemic, and they just don't grow ureteral tissue. They grow something else, and so they don't make a lumen. So thanks for bringing that point up, Leslie. I appreciate it. Maggie, do you have anything you'd bring up?
No, I mean, it was fabulous.
I don't need. Okay.
I especially liked how you gave some examples of the good old days and how people were a little less afraid of the ureter. And certainly, I think that trainees from an OBGYN background are always a little bit more skittish around the ureter. But as you mentioned, it has really good healing properties. And I feel like we should always respect the ureter, obviously. But I think we should all be very comfortable understanding what those healing properties
Yeah,
are.
for sure. And I think other than healing properties when you divert the urine. So if you just get the damn stent up there and feel comfortable with the stent and you're not having that huge barrier where you're feeling uncomfortable calling a colleague in and you learn to place it yourself, those are situations that is absolutely in our armamentarium. And I know all three of us are big advocates for that. So let's start our cases, okay? So Leslie, a colleague consults you the day after they performed, the uneventful laparoscopic total abdominal hysterectomy, BSO, for fibroids, and they have removed the catheter. They're calling you and your service because suddenly this woman has a large amount of vaginal leakage with the Foley removal, and they want you to come see her. In fact, there's even a note from one of the residents that says, rule out fistula.
Yeah, so I think hopefully this isn't occurring too often in your place, but I think like Beth said during her presentation, this is an unrecognized injury, right? You don't get a fistula formation in 24 hours. You don't have an epithelialized tunnel. This is an unrecognized injury, genitourinary injury. And so it is most likely coming through the cuff. That's the point of weakness. Even if it's a watertight fluid finds a way to come through. It doesn't need a very big opening. So I think at this point, now, this is a lot different than somebody coming to your office 4 weeks later. So although we don't always have an opportunity to intervene this early, and there's a little bit of reluctance, although I would say the evidence base isn't great, what do you do around that 2-week period? The tissues are inflamed. You might want to wait. In the old days, as Maggie said, there was this thought that you had to wait 3 or even 6 months till the tissue was completely healed and at 75% of its tissue strength. I think that's been pretty well proven. You don't need to do that in the index patient. I'm not talking about radiated tissue, but in someone that has normal tissue properties as far as we know, you don't need to wait that long. However, this is really early. And so I think you got to figure out where is the urine coming from. Remember, this was a hysterectomy. So this could have come from a bladder injury. It could have come from a ureteral injury, especially if it was a large fibroid uterus, especially the distal ureters. It can all get very distorted. It can be, the ureters can be even, stuck to the uterus and the fibroid. So I think you got to figure out where is it coming from. And everybody knows this is classic testing, I think, on urology, on FPMRS. You have to really evaluate the entire urinary tract. So that means the bladder and the ureters. Now, there may be certain situations, I think in this situation, you want to really evaluate the ureters and bladder at the same time. So could you do a quick bedside cystoscopy and just see what the inside of the bladder looks like? Maybe, but I think going to the OR if you're able to and just doing that cystoscopy and a retrograde also gives you the opportunity, like Dr. Mueller was saying, if it is a ureteral injury, it's so early that this will be actually a pretty good time to have a success rate of actually getting that stent across the ureter before maybe scar tissue comes in and it gets obliterated. So I think it's actually a great window for that.
Leslie, wouldn't you, I see many people in this situation would order a CT scan. And why would you say no freaking way with the CT scan?
Yeah, so the CT scan, I think is something you want to do to evaluate the upper upper urinary tract at some point, but this is someone who just had surgery. You're not worried about a fistula. You're worried about an injury that happened less than 24 hours ago. So yeah. I think actually in this situation, you're going to need to do a cystoscopy anyway at some point. I think you might be able to evaluate the entire urinary tract with the retrogrades. Now, you could make an argument that and you could even get a stent across. If you're unable to completely evaluate maybe the upper urinary tract, like the urine stops and doesn't go cephalad, maybe you'd get a CAT scan at that point. But I don't think it needs to be your primary test right now when you know you have an unrecognized injury.
Yeah. What would you do, Maggie? Anything different?
I mean, I think that's exactly what I would do. Teaching is that, I think that they're in-house. You want to do a cystoscopy anyhow in a retrograde. Teaching that, you get a CT urogram, you could potentially miss the distal aspect of the ureter would be one concern. And the situation, this patient had a hysterectomy. I think it's probably very reasonable to do a cystoscopy retrograde, have everything ready to place a stent. For trainees that are going to be involved in obstetric injuries, this is a slightly different scenario. If you have a forceps with a uterine rupture or something like that, and it turns into a bladder rupture, which would present in a very similar way, you take these people to the operating room for an exam under anesthesia and a cystoscopy. And oftentimes what happens is the entire bladder is open to the level of the trigone. There's a portion of the cervix that's, lacerated up into the uterine incision. I would not plan to repair that even if it was in the first couple days. I would put a Foley in and plan to come back because the likelihood that would be a successful repair is so low.
Maggie, I think that's a great point. I had a patient who had kind of an emergent C-section after a trial labor, and she was tiny, and it was basically just a through and through hole. I think the baby was delivered through the vagina actually, but anyway, it was a huge fistula, and I saw her later on, but when I went through her records, I think she did have leakage or lamb, but like you said, you have to just wait.
Yeah. Okay.
But what we also talked about, like that being a ureteral injury, if it's a bladder injury, I guess another thing for discussion, are you going to have the patient consented for right then and there to do a laparoscopy and exploration and fix a cystotomy as well?
Yeah, I mean, I think that is one of the reasons why I think you brought up that point. It really can be beneficial to do a retrograde. To do a bedside cystoscopy. You know what I mean? Flexible. Another option is just irrigate her bladder, right? You put in 200 cc's, and if you don't get it back, she's got a cystotomy. It's pretty straightforward. I would be like putting all my money on cystotomy, and I'd be talking about laparoscopic procedure, to go back in and open up those laparoscopic incisions. But I think the real benefit for me that I think is versus testing, you get a gal like this, she's ready to go home. You told her it'd be a one-day surgery. Now you're futzing around with that CT scan, which is going to be 6 hours. Then you're futzing around the next day with surgery versus just trying to get her right on the schedule for surgery and potentially dealing with the issue the same day, and she can go home the next day versus the next day you're green carding her or whatever your process is at your OR to get in, and you're an add-on. So now it's another day. So, it's about moving right away on something that's pretty obvious, even if you don't know. Okay, well, I saw this little thing pop up, and it was a thing from Peter that asked if I could share the screen about the question. So I'd like to do next for the next question, which is directed at you, Dr. Mueller, is to just show the question, and then I'll drop the question, okay? Yeah. I know we speak it really fast. So give me a second to futz around with this, and I can't even find my thing.
Maybe Colleen could do it.
Colleen, can you share case number 2?
There we go.
Okay, now I can't see anything. Are you trying to, do you guys see case number 2?
I did for a second. Now I see beautiful purple flowers.
Oh, that was me. Okay, so really I am the person who's in charge. I'm the boss of my own self, and I didn't even know it. Okay.
Now we see the slides.
Okay, good. So let me go to slide number 2, our case number 2. So, hey, Maggie, Dr. Mueller, during a retropubic TVT sling placement, you do the case, and I'm just saying that this case, you're one of those people who really does the minimal sling dissection. Do you know what I mean? There's still the people who kind of make it more like a fascial sling and make the big sling tunnels. You're the mini gal. You got the little incision, You haven't done that much, you pass it, and boy, you're through the urethra on one side. So you put the scope in, there you are, you're through the urethra. What next? Do you, so you, of course, you're not keeping it in. Do you got to go close that?
Yeah. Yeah. So step one, after I, have a mini panic attack, is to, obviously we would be removing this sling. So I would take the sling out. I would recysto to see what things look like. This is something that I would be repairing, at the time of this surgical procedure. So unfortunately, given my minimal dissection, I'd have to make that more maximal. I would dissect down. I would try to get, a couple layer closure in this area. And if I had really good mobilization and lots of good layers, and I felt really confident and this patient didn't have many risk factors, I would consider placing a sling, hopefully more distal than where I was.
Yeah, for sure. For sure. Leslie, how about you?
I don't know. You said it's right at the bladder neck.
Right at the bladder neck, yeah.
Yeah, I find the bladder neck so challenging. It's like a terrible place. It can be difficult to get to, and really because the pubic bone's right there. There's like no tissue anteriorly, very little anterior to the urethra. So I find it a challenging area to get to and to adequately mobilize. And I sort of wonder, I don't know that there's a completely right answer here. I would be a little hesitant. I know if you leave it, you worry about a fistula, and that's a really hard place to fix a fistula. On the other hand, during the mobilization, could you make the problem worse? I don't know if there's a role, given that your dissection is pretty minimal. It's mostly trocar placement. Could you just decompress it with a catheter, and maybe if there's enough good tissue around it, it would heal? I don't know. It's sort of not quite like the bladder injury where, of course, you're just going to leave a catheter and let it heal. And it's not quite that mid-urethral injury where you're looking at it. So it's sort of a tricky place. I don't know. Is there evidence to guide? I can't say.
No, I don't think there's evidence. But I do think both viewpoints are so valid. And I think they really depend on the situation. I've been in that situation, and I tended to be more of a dissector, like dissect more. And I've usually, my perforations of the urethra when they've happened have been more in the mid-urethra. But I had one, I was doing a colpoclasis I did a colpoclasis on a woman whose pre-op cough stress test was negative when I reduced her. And of course, how like life, she comes back and she's got stress incontinence. So I was going to place a retropubic sling on her, and I didn't take down I didn't take down the perineorrhea. I probably should have made a perineorrhea and taken it down, but I just couldn't get my hand right. And I perforated the bladder, and then I perforated the urethra. I'm like, okay, I'm done. They didn't have a TOT in the room. I would have just placed a TOT. They didn't have one there. I was at that little joint I was telling you guys about earlier. And so I just stopped the case. And I just closed it. I was like, oh, it's far away. It's a good 3 centimeters from where my vaginal incision is to that bladder neck. It was a straight perforation. She's not bleeding. And then I panicked for about a week and a half or 2 weeks. But later I thought about it. If there's a lot of tissue between it, but again, there's times where I've perforated and I've actually seen, it presents with, I see urine coming down the tunnel when I've perforated the urethra and the bladder before. They're very different. You have to go and close that and all the layers that you're talking about. It just depends. And I've actually perforated the bladder and had it bleed. Had urine coming down. So, really had to go in and close that whole sling tunnel too. So just good thoughts. I think what it demonstrates to me is how it is that, and I think it's true, most of these things really are about the situation you're in at the time. Agreed? And thinking through it and thinking through all the factors.
Hey, Beth, I do agree with one of the things you said about more so than just closing the epithelium like you might normally do. If you can't get to the exact area, at least try to, this is just my opinion, but just try to get some of that good tissue together over it, and maybe with the blood supply, even though you don't have a mucosal to mucosal layer, maybe with decompression it'll heal.
Oh, of course, and that's of course the principle behind the LATSCO, right? The LATSCO really is about building tissue between the bladder lesion and the vaginal potential incision, and you're just bulking it up. So those are always the principles, I think, between fistulas. Distance between the entry and the exit, you know. Okay, I like that case. Let's go to the next one. How are we doing with time?
We have a few question and answers, so I don't know what the protocol is for that.
Okay, let's go to, when we talked, we kind of talked a little bit about that sacrospinous question. Can we go to that one? And I kind of teed that one up for Maggie. But let's just talk through that real quick, and then we'll take questions from the audience. Now, for some silly reason, I can't move my slide. Oh, there it goes. Okay. So here you go. During a cystoscopy following a uterosacral ligament suspension, bilateral, you did not do a HIS at the same time. This is a pure uterosacral ligament suspension. You notice that you have no efflux of urine from the right side. So you go ahead and you take down all the sutures on the right side, and still that efflux is not great. You're comparing it to the left side. The right side doesn't look as good. And you decide to perform a retrograde. Well, you do the retrograde, and yeah, the contrast goes all the way up to the kidney. You know, the kidney's patent, nothing about it looks squirrely. However, you see extravasation throughout, kind of like the distal part of the ureter. Has that ever happened to you, Maggie?
Oh, yeah.
Oh, well, so what do you do?
I mean, when this has happened, first of all, clearly having a bad day with my TVP.
It's 9 at night now.
Thankfully, it's just a unilateral obstruction and now extravasation, and thankful for that.
Yeah.
So if this was just a uterosacral, no hysterectomy.
That's right.
And I, was able to pass a stent easily, I would feel pretty confident in just placing a stent and leaving it. And I'm so thankful that you've already discussed the fluid dynamics, because you have a degree in fluid dynamics, right?
Yes, masters, yeah.
And the importance of keeping a Foley catheter, because I wouldn't do a good job of that. But I would stent her, probably leave it for 6 weeks, keep the Foley catheter in for 2 weeks, and then reevaluate.
Okay. If we could just take the time, either one of you, I don't care who, maybe Leslie, you explain, why is it so critical that a Foley catheter is in place with a ureteral stent?
Yep. And so this is
a ureteral injury.
This is when you have a ureteral injury. So the stent is great because it acts as a scaffolding that the tissue can heal over, but it also allows as a conduit that the urine can reflux back up to the kidney. So I don't know if y'all have ever had to order a Lasix, a renal scan, but it's a nuclear medicine test that gives you function of the kidney, but it depends on kidney drainage. And so it's quite common that the test comes back inconclusive because there wasn't a Foley catheter and there was reflux at the same time. So, but in this instance, when you're actually, you're not wanting urine to reflux back up, you have to keep the bladder decompressed with a catheter.
Yeah. I mean, I've had 2 cases now, one each a little bit different, where a woman had a fistula, they placed a stent, and suddenly she had more leakage coming out of the vagina. And that's because now the urine from the kidney ureter stent allows reflux. Now all the urine from the other side is going up to the other kidney and now coming down that fistula. I had it one time where she had more urine coming out of the vagina. The other one got very, very sick with more peritoneal drainage and got absolutely distended, and she was fine before that. Before, she just had some leakage. After they placed the stent, now it really, without the Foley. So really always remember, when it comes to the ureter, if you have a stent, you have a Foley. And then, you can take the Foley out in a week or a couple weeks. By that time, there's been enough healing of the ureter that there will not be urine coming out. So thank you guys for making that point. Well, Jocelyn, why don't you take us on some of those questions other people are asking?
Perfect. Thank you so much, Dr. Mueller. That was an amazing presentation. I'll go through some of the questions over here that relate to the cases. So Dr. Claire is asking about the bladder neck injury, and I think I know the answer, but she asked if that repair would be vaginal or if there's a scenario where you would have to do an open or spacer retrodus repair?
I would try to repair that vaginally.
Yeah, I really, Leslie, what do you think? Leslie, can you hear us?
Oh, sorry. Yes, sorry. I had the question panel up and I was reading.
Okay.
Sorry. What was the question again?
It's about, would you ever repair this through the spacer retrodus?
Oh, you know
Hard
what?
to
It is
share
a really hard place to get to. I remember when Toby Chai we worked together at Maryland and at Yale before he went to take the chair position at Boston. And for a neurogenic patient, he had a couple cases where he was actually trying to close the bladder neck and bring the bladder neck sort of and I would get my extra long vaginal instruments to get down there. It is very hard to get to a
Yeah,
down.
I would have to say, yeah,
but
the way the injury is made is the way predominantly it should be repaired, and consistent. And I can tell you, I've done all sorts of squirrely things and gotten myself in more trouble thinking in my mind I have an idea of what the anatomy is. I'm telling you, you're not right. If you can put your finger in and feel where that incision is, or you're very close to it with your fingers, we're only a couple centimeters from that injury when we're vaginally. Abdominally, we are a good foot.
And the pubic bone's right there. It's hard to get under the. It's just a difficult area.
So I've been tempted to do stuff like that before, and it's always been a disaster. So, good question, and a question we deeply appreciate. Thank you.
The next question from Dr. Quiroz, wanting to know, and we touched on this a little bit already, about the role in decision making in placing a sling at the time of a urethral injury. It sounds like it depends on the location, on the patient, on the clinical situation that you're in, but if you could talk on that a bit more.
You're asking, is this is in regards to Dr. Mueller's comment that she might repair that and then go ahead and place a sling?
And then put a sling, yes.
Yeah. Maggie, how do you want to answer that? We can't hear you, sweetheart.
Yes, sorry, I got muted and tried having some technical difficulties. So I think that I would, again, it's really patient dependent, and it depends on the tissue, the integrity of the tissue, whether or not I was able to mobilize. I think we covered this. It's not a really easy area, but again, if I somehow had super tiny tunnels and I perforated the urethra at the bladder neck, I would really hope that my TVT, when I went through my steps of how to place my TVT, it would be much more distal and not overlying any of those suture lines. So that would kind of go into my my decision making. I think the most conservative thing is to not place a sling. I think.
The board answer is of course not, but we're having a real talk here, and so yeah.
If I got a younger patient who was adamant on a sling and I felt like I was able to get a good repair, I would definitely consider it.
Okay, great.
So, hey, one we didn't talk about that I really meant to. So one of the cases was, you do a sacrocolpopexy, and Leslie, this was for you. You do a sacrocolpopexy, you get a cystotomy, you close the thing, and oh, by the way, this gal was signed up for a retropubic TVT at the same time. What's your thought?
Yep, I've had this one too. So even though, some people might say, oh, where you put your sling, it's not in the same place. Like you're not really risking worsening the injury. And that's true. However, the thing I get concerned about is that sling works by some relative level of bladder outlet obstruction. It may not be clinically overt, but we know based on urodynamic studies that that's the way that it works. Now, I know people don't go into fluid retention all that often, but you have a mesh there, you have a fresh suture layer. I think that's all fine to do. I would still do the sacrocolpopexy and close it, but I really don't want any increased intradetrusor pressure that may stress that repair. I think coming back and doing a sling at a later time, it's a quick outpatient procedure. I know from the patient standpoint, it's time off of work and it's burdensome, but I don't know. You're already probably a little bit like, I have a suture line and mesh there. I know it's okay. It's okay most of the time, but I would just be concerned about kind of that intrusive pressure, the bladder outlet obstruction, the risk of retention, even if it's mild.
Yeah,
that
and
sling could
that's,
produce on the
yeah, and then
healing
that
process.
suture line's starting to break down about the same time you're taking that catheter out. You know, at that 7 to 10 day region, you know.
When it's
Nikki,
still
what
healing.
about you? Have you been in this situation, and what do you typically do?
Yeah, so again, I have been in this situation. So to be completely honest, I placed my sling before the colpopexy, so I would kind of really leave that because I
Yeah,
wouldn't.
of course. Yeah.
But I definitely see where you're going with it. And I would be much more careful. I would leave the Foley in, you know, for definitely that 2-week time frame. And I would be really careful with my voiding trial and give the patient a lot of precautions. But I would leave it in.
Yeah, I think if I'd already placed it, there's no way in hell I'd take it out.
Right.
That sounds insane.
We're
You
doing
know?
them first.
Yeah, for sure. Okay. Not even a question, you already did it. Okay. Jocelyn, anything else?
And since we're still on the topic of bladder injuries and Foley's, one of our participants asked if you recognize an intraoperative TVT trocar injury, would anyone leave a Foley in that patient?
Not typically. I'm not these days. No.
No.
For the reasons that you said, because the injury's in the space of retius. So
Yeah, I think the only time I'd be a little worried, I have, you know, I've been in, when TVTs first came out, I would get consulted to the OR. We placed the TVT trocar through the dome. Now there I was having a heart attack, and I wasn't worried about the bladder, I was worried about the bowel. But they were never through the dome because the air bubble was on the anterior bladder wall. That's the highest part of the bladder. But people think wherever the air bubble is, there goes the dome. And so then I was freaking out, but not, I don't anymore. I just,
You know what? I still leave the catheter in for a few days, kind of, and this is all theoretical, but I worry, and it's not because I'm worried about intraperitoneal leakage or sepsis. It's more that I have a foreign body outside the bladder, right where that injury is. Even though I know it's going to re-urethelize really quickly, could there be some urine spill there that could infect it? That's the only thing I worry about.
Sure.
Unproven.
Sure. And you mentioned being called into the operating room as a consultant. So say that a OB/GYN trained FPMRS surgeon calls urology into the operating room. Could you give a quick list of things we could start getting ready?
Oh, absolutely. I think this is, yeah, it's a beautiful question. In fact, I want to tell you that I think people who do these procedures like Maggie, Leslie, and I, you can absolutely help your colleague. The note I write is so important, I believe. I walk into that room, I look at the situation, I ask the anesthesiologist how much blood the patient has lost. I look at the demeanor of the surgeon. Before I come into that room, I ask them to have the C-arm ready. I ask for the urology scope because typically if I'm going to pass a stent, the 17 front sheath on the regular cystoscope is not sufficient to pass a stent. And who needs all that hemming and hawing when they've been waiting for me already for 30 minutes? So all of those things, ask the person what equipment they need, ask them what they would like in the room. And plenty of times I go up to the side of the table if it's an open case and ask them to just orient me to what's going on. Don't ever leave. I've actually seen that where people walk out of the room while I'm doing my part. Why would you ever do that? First off, I need that person to kind of tell me what happened, what's going on, you know, and I'm good. And still I can get a little disoriented about what's going on if it's a case I'm not familiar with. And in my note, if you're the person who's doing this, come in and talk about how the room was under control. The patient lost very little blood. When you stepped up to the table, it was hemostatic. The surgeons helped point out where they believe the injury was. All of these things in any kind of legal matter look so brilliant. They're just a confirmatory that the surgeon was awake at the wheel. And likewise, I've told the truth when I've stepped into a bad situation. Nothing blatant, but just I walked into the room. The anesthesiologist was concerned because the patient wasn't stable. It took me 40 minutes before I could get visualization, and I needed to call in a colleague of mine to help me. Those are all indicators that if there's something that was really traumatic, that it's not just up to me. I walked into a situation that was very difficult. So learning to be good with your notes and document the experience that you're seeing, take the time to do that is very important. And I always go down and talk to the patient with my colleague. It has been one of the ways that I've built some of the deepest relationships with my colleagues who feel awkward at the time, and I am able to say what they can't. Boy, this doctor was great. They noticed this, they called me right in at the perfect time, and I was able to help in these ways. And that builds up that physician who's feeling terrible. And also builds it up in front of the family and say, and all I do, I look like a hero in both situations. It's really ironic, you know. I walk away feeling really connected to people, and also like I helped a difficult situation.
Right. That's amazing advice. Thank you so much. It looks like we are out of time. It's 6 o'clock. I'd like to thank Dr. Mueller for her wonderful presentation, to our panelists, Dr. Rickey and Dr. Mueller, for a great discussion. Thank you for answering all the questions from the audience. And thank you again to AUGS, SUFU, and SGS for putting together these presentations. I think I speak on behalf of all fellows that we have been loving them. Thank you so much. Just a reminder that we're putting these on every Tuesday and Friday for FPMRS fellows and anyone who wants to join. The next one will be on Friday, May 8th at 10:30 a.m. Eastern Standard Time, and we look forward to seeing you then. If you can't watch the live broadcast, you can always watch the archived version on the Society's websites and find it on our YouTube channel. Just search AUGS Fellow Lectures.
Okay.
See you next time, and
Dr.
everyone stay
Fitzgerald,
well.
did a good job to you too.
Thank you.
Okay.
Thanks, Jocelyn.
Good night. Okay, take
Thanks,
care.
Jocelyn.